All right, we're ready. Christine told me she only had 25 minutes of content, so I've been secretly ruining the Zoom for a little while just to buy some extra time. Dr. Chung is needs no introduction, but is one of our faculty since 2020 in the structural heart world, has done an amazing job. She joined us after interventional and structural training at Columbia, residency at Brigham and Women's Hospital, med school at Drexel, and currently spearheads a number of really important initiatives in our group and to our program, including from the interventional side, the LAAO program. We're starting a PE program that sort of PE response team that Christine has been really running and has been doing a ton of work on the cardioembolic side of things, which is the topic for today. So Christine, thank you so much. Have at it. Do you need this?
I don't think so. I'm speaking through this, right? Okay. Yes. I think we'll just go without it. Okay, wonderful. Thanks so much for that introduction. We are going to be talking today about the many different causes of cardioembolic stroke, how to diagnose it, and how to manage it. I think for many of us as cardiologists, stroke is a topic that's a little bit less familiar and accessible to us. So I thought this would be a nice way to kind of take a tour through this together. These are my disclosures. Okay, so this is a nice infographic from the American Stroke Association showing that cardioembolic strokes are increasingly prevalent. In this country, ischemic strokes make up by far and away the largest proportion of stroke. It's nearly 85%, with hemorrhagic strokes making up a pretty small minority. And because of the fact that cardioembolic strokes are associated with a lot of conditions that are in the elderly population, as the overall population is continuing to age, cardioembolic strokes are actually becoming increasingly prevalent. And one of the important things about cardioembolic stroke on the PowerPoint. Like that? Yep, perfect. So cardioembolic strokes are more severe and are associated with a very high morbidity and mortality. So at 5 years, 80% of people who have had a cardioembolic stroke will have died. There are a lot of different things that can originate in a variety of places within the cardiovascular system and ultimately make their way to the brain. So this represents a really heterogeneous group of patients. So some common places where cardioembolic stroke can originate include the aortic arch. There can be various forms of cancer-related, non-infectious endocarditis. Valvular heart disease, including both native and prosthetic valves, are a known source of cardiac emboli. And then, of course, there's paradoxical embolism related to PFOs, as well as some degree of intrinsic clot formation that happens directly in the atria, whether in the main chamber or in the appendage, that are related to underlying atrial cardiomyopathy, as well as directly related to atrial fibrillation. In terms of their clinical presentation, so unlike some other forms of stroke, like lacunar strokes associated with small vessel disease, cardioembolic strokes often present suddenly with maximum deficits at onset that tend to slowly improve and resolve over time, as opposed to lacunar strokes or strokes due to artery embolism, for instance, related to carotid disease, that can have a more stuttering course. They do have a distinct neuroimaging profile. So because of the fact that emboli are more likely to lodge in distal arteries, they go kind of follow the main branch and end up more likely to be in the cortex as opposed to the deeper subcortical tissues. But that doesn't mean that a lacunar stroke can't be related to a cardiac embolism, particularly if you have the overall right patient, young, no cardiovascular risk factors, and all they have is a single deep lacunar stroke. That can still be a hallmark of a cardiac embolic stroke. Half of cardioembolic strokes present with multiple vascular territories being affected at the presentation. And then one hallmark would be if you were to have an abrupt vascular cutoff for instance, on a CTA or an MRA in the acute presentation in a vessel that doesn't really have any upstream disease. In terms of how to work up these patients, there's actually a lot of variability in clinical practice out in the community. So almost everyone is going to get some sort of vascular imaging of the carotid arteries, whether it's with CT, ultrasound, or MR. And everyone is going to get a 12-lead EKG. That's pretty standard. But when it comes to things like how hard we look for intracranial disease, as well as how hard we look for known contributors like occult atrial fibrillation, there's a lot of variability. So in our stroke clinics, particularly, the stroke clinic at Harborview, pretty much everybody that gets worked up is going to get either a CT or MRA of the intracranial vessels to look for intracranial athero. But in the community, it only represents about 70% of people that are getting that type of testing. And then there's a big drop-off when you get to TE, as well as how hard we look for atrial fibrillation. So a lot of variability exists in how long we are looking. We now have a lot of evidence that the longer we look, the harder we look for AFib, the more we will find. So this is the Crystal AF study where patients were randomized to sort of usual care with an external cardiac monitor versus an implantable loop recorder. This was done a while ago, so it was the early generation device that was a little bulkier. But you can see that at both 6 months and 12 months, there's a significantly higher rate of AFib detection in this population of patients who had had ischemic stroke without an otherwise known source and had no prior diagnosis of atrial fibrillation. This has now been replicated in a number of other randomized controlled trials. One of the more recent was this per diem study done in Canada, about 300 patients that did have ischemic CVA with no prior history of AFib with a median CHA2DS2-VASc score of 4. And when the folks got randomized to either implantable loop recording versus external cardiac monitoring, there was a almost threefold increase in the rate of detection in people that had been monitored for longer. What none of these studies is really powered for is to know whether the people that then get detected to have AFib, if you go ahead and treat it with an oral anticoagulant, whether that then goes on to meaningfully prevent ischemic stroke. So if we find it, should it all be treated the same? So is subclinical AFib the same as clinically detected AFib? So there have been a number of studies seeking to answer this question. The ASSERT study is one of the original ones looking at about 2,500 patients that were sort of enriched for an overall demographic that is more likely to go on to develop AFib. So a little bit older, they had a history of hypertension. Within about 6 months of their index stroke, they had all undergone some form of implantable cardiac device, whether it was a pacemaker or an ICD. And over the next several months, you can see that 10% went on to then go on to be detected to have these subclinical tachyarrhythmias. And in this subgroup, there was a 2.5-fold increased risk of ischemic stroke and systemic embolism.
Your slides are not sharing. So it's sharing just the Zoom link.
The slides weren't advancing.
Yeah, the slides weren't advancing.
Oh, okay.
So go ahead and we need to get her screen back up. Up there. So we need to share, like start the slideshow for her. No, I think we need to start her slideshow. Stand. Now select PowerPoint slideshow. Sorry.
No, it's okay.
Yeah, sure. I think that should be okay.
Okay, wonderful. So a further sub-study was done of this group of patients that then went on to have increased risk of the group that had subclinical tachyarrhythmias. There was then a sub-study of those patients done. And then the researchers stratified them based on the duration of these episodes. So you can see here that they broke them down into people that had more than 6 minutes, but less than 6 hours, 6 hours to 24 hours, and then more than 24 hours. And interestingly, even up to 24 hours, there isn't a big signal that there's a significantly increased risk compared to those that have, just over 6 minutes. But once you get to more persistent AFib lasting longer than 24 hours, there's a significant increase in the risk of ischemic stroke. So there is a correlation between the duration of these subclinical AFib episodes that we detect just through increased monitoring and surveillance and the risk of stroke. So then the natural next question is, what happens if you treat these patients the same way as if they had clinical AFib? Are you then able to improve the stroke risk? So this was the Artesia trial, looking at about 4,000 patients with subclinical AFib. CHA2DS2-VASc score was about 4, so a group that if they were detected to have clinical AFib would have a meaningfully increased risk of stroke. And as is often the case in studies where we are using antithrombotics, they were able to reduce the rate of stroke in comparison to aspirin when patients were treated with apixaban, but the apixaban group did go on to have more bleeding. So another question that can be asked is, if occult AFib, subclinical AFib, does represent a significant proportion of the underlying etiology of this group of patients with embolic stroke without an otherwise unknown source, rather than being so granular and trying to really nail down whether they're having AFib, how much AFib they're having, what if we just went ahead and treated the entire group of patients as if they were likely to have AFib and just treat them all with an oral anticoagulant? So there were actually 2 very large randomized controlled trials using 2 different DOACs seeking to answer this question. This was the RESPECT-ESUS trial looking at rivaroxaban. There was a very similar study done with dabigatran, and both of them were negative and did not show a significant reduction in stroke when people that had ESUS and were otherwise undifferentiated were randomly assigned to DOAC as opposed to just aspirin alone. So this has led to the current standard of care, which is that a patient with embolic stroke of unknown source that does not yet have identified occult AFib should be treated upfront with aspirin as opposed to oral anticoagulation. The Arcadia study was seeking to take this very broad heterogeneous group of patients with ESUS, try to select out the patients that were more likely to have an underlying atrial cardiomyopathy, and therefore the hypothesis being that they were more likely to develop cardioembolic strokes that would be effectively treated with oral anticoagulation. So the markers that they used were an elevated NT-proBNP level, a evidence of LA abnormality on EKG, and left atrial enlargement on echo. And then these patients were randomized to full-dose aspirin versus full-dose apixaban. And this study was actually stopped early because there was no signal in any difference between the 2, and it was thought to be futile to continue. One important piece of data that came out of this trial is that in comparison to the studies with rivaroxaban and dabigatran, there was no significantly increased bleeding with the apixaban group compared to the aspirin. So how can we summarize all these years of big important studies? We know that patients with cardioembolic stroke are a very heterogeneous group. So we can't really treat them with a one-size-fits-all strategy. For the majority of patients, as a sort of upfront default strategy, the best medical therapy right now is aspirin alone. In patients that are older and have other coexisting cardiovascular risk factors that might increase the likelihood that they have occult atrial fibrillation, it is very reasonable and currently a class 2A recommendation in the updated AFib guidelines to pursue extended cardiac monitoring with something like an implantable loop recorder. Subclinical AFib does carry a lower risk of stroke compared to sort of classic clinically detected AFib. But this is modified by the duration. So people that have more of it are going to be at increased risk of stroke. And it's also modified by the other comorbidities that they have that would otherwise be reflected in their CHA2DS2-VAS score. So if a patient has even rare episodes of subclinical AFib, but otherwise have a lot of risk factors for other causes of stroke, then it would be very reasonable in that situation to go ahead and treat them with oral anticoagulation, assuming that they don't have excess risk of bleeding. So for our patients that do have a established diagnosis of atrial fibrillation, what are the current new and evolving therapies to try to modify their stroke risk? So there was a lot of excitement over the development of these factor XIa inhibitors that were thought to sort of inhibit the clotting cascade above the common pathway, such that you would not affect physiologic normal hemostasis, but really just kind of target pathologic clot formation. So asundexian was tested in a number of phase 2 trials in a variety of settings, orthopedic surgery, but one of the things that they looked at was patients with non-valvular AFib. And this phase 2 trial was very promising. A lot of the patients, there was near complete in vivo inhibition of this factor XIa, and really a signal that there was less bleeding compared to things like even apixaban. And so this led to a really large planned phase 3 randomized controlled trial. However, just a few months ago, it was terminated early because the asundexian group was having more strokes and systemic embolism. So as of right now, we don't yet have any medical therapies that are looking promising to be a substitute for the DOACs. We have seen in a variety of studies that of the patients that have AFib that would otherwise benefit from anticoagulation for reduction of stroke risk, that there's a very significant proportion that can't tolerate it either for intermittent short periods or in the long run. This was one study looking at a variety of insurance claims, so started with a cohort of over 1 million patients. And of this group, they identified over 12% of patients that within the first year after diagnosis were never on an oral anticoagulant due to bleeding risk. And you can see that in this group of patients naive to oral anticoagulation, that they then go on to have ischemic stroke at a rate that would be very similar to what would be predicted by their CHA2DS2-VAS score. So when we don't anticoagulate our patients with AFib, we very much leave them exposed to this risk of stroke. These patients in this study also had an increased rate of hemorrhagic stroke. So it does seem that this bleeding risk is being appropriately identified. So this represents a particularly challenging subset of patients that are at very high risk of both ischemic and bleeding complications. The latest update to the AFib guidelines, just published a couple months ago, has upgraded the level of recommendation to consider things like left atrial appendage closure in this subpopulation. Previously, it was a 2B, and now the phrasing of the current recommendation is that in patients with AF that have at least a moderate to high risk of stroke as reflected in a CHA2DS2-VAS of 2 or above, those that have a contraindication to indefinite anticoagulation, it's reasonable to consider a non-pharmacologic alternative. So what is the data upon which this recommendation was based? The original PROTECT AF study was the pivotal trial randomizing the first generation Watchman device to Coumadin, which was all that was available at the time. At about 3 years of follow-up, the rates of ischemic stroke and systemic embolism were about the same in the groups, and so it met its pre-specified non-inferiority endpoint. But as you can see in the right-hand graph, there was a signal of periprocedural complications that was potentially concerning. In this group, there was about a 4.5% risk of pericardial effusion. This was, early generation device, early operator experience. So there was a second pivotal trial that was conducted to try to see if they could improve the safety profile of this original device. That was the PREVAIL study. Also randomizing 2-to-1 to the first generation Watchman versus Coumadin. This trial had a very low rate of stroke across the entire cohort. So the Watchman arm in this study actually had an over 2-fold lower rate of stroke than the warfarin arm in all of the major DOAC trials. And so for some reason, this group had a significantly lower event rate than what would have been predicted based on their CHADS-VAS scores. And so the overall rates of stroke were in the low single digits for the whole cohort, difficult to sort of discern differences between groups. And in this study, the primary efficacy endpoint was not met. However, there was a significant decrease in the rate of procedural complications. So the safety endpoints were all met, and the rate of pericardial effusion was cut in over half. This is a meta-analysis of the 5-year outcomes of both of these two pivotal trials, showing that with LAAO devices, this is in a little over 1,000 patients, there is less hemorrhagic stroke and less major bleeding. And once the first generation Watchman device kind of exited the clinical trial phase and entered clinical practice, you can see on the right-hand side there, those are the real-world registry results showing that this improved safety profile has been sustained despite the fact that it's getting rolled out to more centers and more operators. This is the largest published study so far with the real-world outcomes with the first generation Watchman device within the first 3 years of its use. So about 38,000 procedures recorded through the NCDR registry, which is mandated by the FDA. You can see that by and large, the patients seem to be the appropriate candidate. So older, with a higher CHADS-VAS score and more comorbidities than the patients enrolled in the pivotal trials. Yet going on to have very high rates of procedural success, as well as acceptably low rates of procedurally related complications. So what evidence do we have right now directly comparing Watchman to current generation blood thinners? So this is the only randomized trial that we have so far. It's about 400 patients, so it's small. But this was the PROG-17 trial looking at high-risk AFib patients. You can see the mean CHADS-VAS score in this group is almost 5, and the HAS-BLOOD score is over 3. So patients at high risk for both stroke and bleeding. And they were largely treated with apixaban. This was per the treating physician's discretion. And at 3.5 years of follow-up, there's non-inferiority between these groups for the ischemic endpoint. And over time, a significantly lower risk of bleeding in patients treated with LAAO. So all of that data is with the first generation Watchman device, which was effective, but also had a lot of pitfalls. One of the main issues with the first generation Watchman is that what exited the sheath and sort of directly interacted with the thin left atrial appendage tissue were these sort of sharp metal tines. And so in July 2020, we had introduction of the second generation Watchman Flex, which one of the main improvements in this device is that the back end is closed. They also added more struts, which actually makes it more flexible and softer and more conformable. So what exits the sheath and interacts directly with the tissue is actually a deflectable ball. So you can actively push against the appendage with the ball, and it will actually deflect rather than go out and exit through the wall. So this was the IDE study, single arm, just registry, looking at this second generation device. In about 400 patients, you can see that the rate of major complications fell dramatically and was about 0.5% in this cohort. As the Flex device then entered real world practice, we have continued to see that this safety signal holds. So the SURPASS analysis is sort of an interim analysis of the first 2 years of real world use of the Watchman Flex device, again, through this NCDR data. And the safety profile is excellent, with major complications being somewhere around 0.5%. We do have other devices that are FDA approved for LAAO. So this is the Amulet device. And this was approved after a head-to-head comparison between the first generation Watchman and this Amulet device. There were similar rates of stroke and bleeding. We now have 3-year follow-up in this patient cohort. There is a higher rate of pericardial effusion and device embolization with the Amulet device, but it seems to get better complete seal, which is one of the Achilles heel of the Watchman device, is that because the appendage ostium is so often oval and we're putting in these round devices, you can end up with these small gaps around the perimeter. Because of the design of the amulet, where the distal portion, that sort of cylindrical disc, is mainly for anchoring, and then you have this sort of disc or lid, if you will, that kind of extends beyond the actual borders of the ostium, it can actually result in lower rates of peri-device leak. So both devices sort of have their pros and cons, and there are certain anatomies that may be more amenable to treatment with one versus the other. In the Amulet IDE study, the choice of antithrombotic regimen post-implant was actually left to the operator's discretion. And so the vast majority were treated with DAPT, aspirin, and Plavix, as opposed to the Watchman arm, which was required to be on aspirin and warfarin. Despite this difference in antithrombotic regimens, there were similar rates of major bleeding and all-cause mortality at 1 year. And interestingly, there was no difference in rates of DRT, device-related thrombosis, despite the fact that most of the Amulet patients were treated with DAPT rather than oral anticoagulation. So this leads us to one of the big topics that is often discussed in the field of left atrial appendage closure. What is the ideal antithrombotic regimen to have these patients on? And is there any difference in rates of device-related thrombosis? So this is a analysis of the NCDR registry showing that in real-world practice, there is significant variability in how patients are being treated post-device implant. So anywhere from being still on Coumadin to being on a DOAC, combination with aspirin, single antiplatelet, people are doing their best with limited data to kind of tailor regimens for the patient in front of them. Interestingly, there has really never been in any observational study with either the first or the second generation Watchman device that there is any association between rates of device-related thrombosis and post-procedural antithrombotic regimen. This was an analysis of the NCDR registry data with the Flex device specifically, looking to see whether there was any difference in rates of ischemic stroke, device-related thrombosis in people that were getting treated with DAPT versus an oral anticoagulant. And as you can see, there really was no difference. And so this led to the FDA approving an on-label indication for DAPT for the Watchman Flex device. So there are 2 different approved antithrombotic regimens. In some patients, particularly those that are felt to be at such high risk of a bleeding complication that they are off of everything, there is a little bit of data that half-dose apixaban might be a way to kind of split that middle ground. So this is a prospective registry done out of a hospital in Texas where patients got the first generation Watchman device and then were treated at the physician's discretion with either a standard anticoagulant regimen, meaning 45 days, step down to 4.5 months of DAPT, and then down to aspirin, which is sort of the original regimen that was used in the pivotal trials of the first generation Watchman device, compared to half-dose apixaban. So regardless of whether they would otherwise have met that dose reduction criteria, using half-dose, but doing it for a prolonged period of time. So in this study, the majority of these half-dose DOAC patients were getting treated for a year or longer. And in this study, there were actually lower rates of device-related thrombosis and ischemic stroke in the patients that were getting treated with this prolonged regimen of half-dose apixaban. So certainly small numbers, it's observational, but interesting. And for some patients, I think provides a little bit of data to say that this may be a reasonable option for people that are kind of between a rock and a hard place. We have a randomized trial going on right now in over 2,500 patients looking at a lower risk, sort of all-comers population of patients with non-valvular AFib that don't have any bleeding contraindication to really try to tease out whether percutaneous left atrial appendage occlusion may be a suitable and equivalent upfront alternative for stroke risk reduction in these patients. So that's the Champion AF study. It is probably going to report its first results within the next year or two. In this study, the post-implant antithrombotic regimen is actually left up to the physician's discretion. So we'll get some randomized data out of this study over what may be potential differences between a platelet-based approach versus an oral anticoagulant-based approach. There is a very similar randomized trial of the Amulet device compared to current generation antithrombotics in a lower risk all-comers population of patients. In this study, the post-implant antithrombotic regimen will be 3 months of DAPT. There are ongoing developments on the device design standpoint as well that are seeking to address this issue of device-related thrombosis, because we obviously don't want to substitute one risk of stroke for another. The third generation Watchman Flex Pro, which has completed its IDE study and is going to be sort of widely released throughout the market very soon, has a proprietary antithrombotic coating that has been shown in benchtop testing as well as animal models to preferentially bind albumin as opposed to platelets, and has been shown in animal models to lead to less thrombus formation and better endothelialization of these devices. So the hope is that this translates in patients to lower risk of DRT, and there will be an upcoming 3-arm randomized controlled trial with the Flex Pro device, looking at some sort of single antiplatelet regimen versus DAPT versus oral anticoagulation. The final study design hasn't yet been released. And then finally, there are many novel devices that are in the pipeline. As you can imagine, with the growing number of patients that have AFib, the significant proportion that are not going to be eligible for lifelong anticoagulation, there is a real clinical need here. So there's a lot of activity in this space. The 2 investigational devices that are furthest along in the pipeline are the conformal device pictured on the left. This is a foam-based matrix that is supposed to be even more conformable and specifically kind of seeking to address that issue of residual leak. They published promising results in an early feasibility trial and are currently in a pivotal trial randomized against the Amulet and Watchman device. Pictured on the right is the laminar device, which is a totally different approach to this issue. Because of this concern for DRT, this is really seeking to minimize the implant footprint on the left atrial blood-facing side. So this is a sort of like a blender ball. It kind of goes into the middle of the appendage, interacts with the tissue, and then actually like turns it as if you're sort of tying a twist tie around the ostium of the appendage, and then kind of holds that in place with this little clip. There were animal studies as well as a first-in-human series of 15 patients published where there were 0 complications and also no device-related thrombosis. So this technology was acquired by Johnson & Johnson recently for $400 million and will probably be heading into a big trial somewhat soon. So we've all seen that there is a very small subset of our AFib patients that may be tolerating blood thinners just fine, but still are going on to have recurrent stroke. So what is happening in these patients? Of course, we know that there are a significant proportion that are not able to consistently take their meds for years and years. But there is probably some subset that are going on to stroke due to other causes that are associated with AFib, but aren't directly related to clot formation in the appendage. So what can we do for these patients? Is there anything that we can do to adjust our approach to try to optimize outcomes in this population? So this was actually a surgical study done a few years ago, largely in Canada, where they randomized patients that had a primary indication for cardiac surgery. They all had AFib, and then they were randomized to either concomitant surgical appendage ligation or not. After their surgery, they were all continued on systemic anticoagulation. And at a follow-up time point of 3 years, you can see that even on the background of very high adherence to oral anticoagulation, and the majority of these patients were treated with apixaban, there was still a significantly lower rate of stroke in the patients that got concomitant surgical atrial appendage ligation as well as continued on their anticoagulant. So this has led to the design of the LEOS 4 study, which is the same study design, just randomizing patients to endovascular closure with the Watchman device as opposed to surgical ligation. And it's seeking to see whether in the highest risk patients, so people have to have either a CHA2DS2-VASc score of 4 and preferentially permanent AFib, but if they have paroxysmal AFib, they have to have had a prior stroke or TIA to qualify for inclusion. And we are currently in the process of being evaluated as a potential site for this study. So to wrap up, what we know so far and currently have available to us for our population of patients with clinically relevant non-valvular AFib, DOACs do remain the standard of care. There is a lot more evidence on their long-term efficacy and safety. However, significant improvements in the safety of left atrial appendage closure has made it a more appealing alternative, specifically for patients that are at increased risk of bleeding complications. There is going to be a lot of data coming up soon about whether or not this device therapy is potentially expandable to other types of patients, not just those who are bleeders. And there are many novel devices in the pipeline that are seeking to improve on some of the current weaknesses of existing devices, which are residual leak and device-related thrombosis. And eventually, we may have more data to discern whether certain patients at the highest risk of stroke may benefit from a belt and suspenders combined approach. So in the last few minutes, I'm going to switch gears a little bit and talk about cardioembolic stroke related to PFOs. So a few months ago, Eric Krieger turned me on to this sordid tale of this interventional cardiologist in Utah who was doing hundreds, if not thousands, of PFO closures in patients in the early 2000s, many of whom had never had stroke, had never had TIA, really didn't have a strong indication for it. So what is it about PFOs that makes them so potentially amenable to this type of abuse? So we all know that PFOs are extremely common, and we tell the vast majority of people that this is an incidental finding, it's benign, it's a normal variant of normal congenital anatomy. However, we do now have a lot of evidence that in a very, very tiny subset of these patients, it can actually go on to facilitate a very potentially devastating problem. And so how do we sort of put that together in a way that is rational? So the best randomized controlled trials of PFO closure were extremely stringent in their inclusion criteria, really seeking to filter out patients that had stroke related to other causes. So all of the major pivotal trials included intracranial imaging, looking for intracranial athero. If there was more than mild stenosis of things like the carotids or the intracranial vessels, those patients were all excluded. However, because all these trials took place prior to the understanding that we now have that many of these patients do go on to be diagnosed with occult AFib, none of them required prolonged cardiac monitoring, and what was required was variable. All of these patients had a transesophageal echo in addition to TTE to understand the anatomy of their PFOs. And so to a variable extent, these trials really primarily included patients that had either atrial septal aneurysm or a larger shunt. So the size of shunt is not usually defined sort of by the diameter of how wide the tunnel can stretch, but through a functional assessment of the amount of bubbles that it allows to pass right to left. And so in most of these studies, it was designated that if they had a grade 3 or 4 by TTE or TEE, that would be classified as a moderate to large shunt. In patients with a PFO-associated stroke that remain just on medical therapy, the risk of stroke recurrence is quite low. It's around 1% per year and is generally lower than the risk of recurrence in patients that have stroke related to other causes. And so when trying to weigh the risk and benefit of an intervention in this patient population, it's important to keep this in mind. And this is part of why when patients are older, we are a little bit more careful and thoughtful about what their ultimate benefit is going to be, it's because the shorter you have left to live, the less you accrue a benefit that is already, pretty low. However, the meta-analyses of the randomized controlled trials have shown that when you do identify a high likelihood of a PFO-associated stroke, there is no difference in benefit to closure in the older patients. So people who are older benefit to the same extent as those that are younger. So it's not so much about the age of the patient, it's about really trying to drill down to discern whether PFO was indeed the most likely cause of that patient's stroke. So then how do we do this? So routine, sort of as a first pass, is TTE bubble study. However, the sensitivity of this is extremely low. And in clinical practice, we often see patients that have 0 shunting on a transthoracic and go on to have even grade 4 or 5 on transcranial Dopplers. And so increasingly, our stroke neurologists are preferentially obtaining transcranial Dopplers to assess the size of shunt. And often we can, sort of combine these together. You might get some sense of whether there's redundancy of the septum on the transthoracic. You get some sense on the TTE bubble. But if you have a patient that has a small or negligible shunt on transthoracic echo, but otherwise clinically seems at high likelihood of having had a PFO stroke, that is a patient you should definitely send for transcranial Dopplers, because you don't want to miss the possibility that there is a PFO just based on a negative transthoracic bubble. And the reason why TCDs are so much more sensitive than TTE is because you get 2 input signals to make the diagnosis. So, they inject bubbles through a peripheral IV, they insunate the middle cranial artery, middle cerebral artery over the bone. And then you get an auditory signal based on how many bubbles are being detected in the systemic circulation. And then you also get these sort of vertical white lines that corresponds to individual bubbles. And although you can't easily count them, it is somewhat easier to kind of grade that there's a little versus a medium amount versus a lot, as opposed to looking at bubbles on a TTE. So we now have up to 5-year follow-up data from 3 randomized controlled trials of PFO closure. This is a meta-analysis of all the PFO RCTs that we have so far. And you can see that by and large, there is an overall benefit in terms of stroke risk reduction in people that undergo closure as opposed to remain just on medical therapy. The PFO population does represent a significant proportion of strokes in younger patients. And this was a study that introduced the Pascal classification as a partner to the ROPE score. They, in the Pascal classification, included anatomic risk features, including the presence of an atrial septal aneurysm and a larger shunt. And in a patient that has a high ROPE score, those patients are classified as being most probable to have had a PFO-related stroke. People that are sort of in the middle are possible. And then those that are have a low ROPE score and no anatomic high-risk features fall into the unlikely category. And what this study showed is that there is a dose dependence where the people that are unlikely by Pascal go on to then have the lowest benefit after PFO closure, and the number needed to treat is many-fold higher than those that are classified as possible, sort of the moderate risk group. And then the people that are classified as probable, according to this classification scheme, have the lowest number needed to treat. It's in the 20s. About 25 patients needed to treat to prevent 1 stroke. And they go on to have the greatest risk reduction. So this is another study just illustrating that although imperfect, the ROPE score does correlate with the prevalence of PFO in patients that have embolic stroke. So this is a prospective registry of consecutive patients that were all diagnosed with embolic stroke. 40% to start had PFO. And then when they used the ROPE score to discriminate people who are less likely versus more likely to have had a PFO-related stroke, that correlated nicely where there was a increase in ROPE score that positively correlated with a much higher proportion of those patients than going on to actually be diagnosed with a PFO. So it does seem that the ROPE score is a useful risk stratification tool. And then in combination with anatomic features, the Pascal classification, I do think has improved our ability to try to have these nuanced conversations with patients about what their personal benefit may be with undergoing a PFO closure. So to summarize, for the entire cohort of patients that we now have studied in our randomized controlled trials of PFO closure, the absolute risk reduction for ischemic stroke across the cohort was 3.4% at 5 years. In those patients that are least likely going in to have had a PFO-related stroke, the risk of new AFib is the highest. So I think it just goes to say that those patients, are more likely when they present to have other cardiovascular risk factors that should instead cause us to head down the pathway of looking harder for AFib rather than presuming that it was their PFO that was the culprit. So thank you so much, and I'll open it up to any questions.
That was terrific. Thank you. I feel like I need to acknowledge something that you didn't acknowledge, but is important, which is that Christine has started a heart-brain clinic at Harborview, kind of a multidisciplinary, very thoughtful, very measured approach to this space that is confusing and really nuanced. And I think that is to your credit, that's wonderful. So let's jump right in.
That was a fantastic talk. I learned so much. I have a question about the PFO. So you mentioned medical therapy. In principle, if thinks the PFO is involved, full anticoagulation should resolve the problem because it's supposed to be DVT going. Can you tell us when it's medical therapy, what is the medical therapy?
Yeah, so the vast majority is aspirin, and that's per the neurologists. Generally, the people that get sent for evaluation for PFO closure from the stroke clinic are on aspirin. There's a very small subset that they will escalate to oral anticoagulation. So for instance, they will often do hypercoagulable testing in these patients. And if there's some, prothrombin gene mutation or something like that, they'll put them on oral anticoagulation. The sort of easiest patients are the ones that have like a concomitant DVT and a stroke. Those patients are on anticoagulation, but by and large, it represents a very small fraction. And I hear what you're saying, and I think the issue is that we just don't have a randomized controlled trial of oral anticoagulant against PFO. And when you look at the data for the ESUS population in general, aspirin is better than or safer and equally effective than oral anticoagulant. So I presume that's why the neurologist, that's reflected in that practice pattern.
Thanks. I agree. That was really educational. I understand why the neurologists are eager to work with you to offer this potential new therapy to the patients where they can't necessarily see a path to using medications alone. Who do you turn down? So when the neurologists present a patient to you and they say, here they meet this sort of criteria that you've laid out based on these trials, are there anatomic considerations or other issues where you say to the neurologists, this patient might meet the criteria for inclusion on paper, but I don't think they're a good candidate?
So I think presuming that it's a reasonably functional patient that has a reasonable quality of life that you're trying to preserve, so just kind of assuming that the substrate is reasonable, the sort of highest risk for intracranial hemorrhage is this entity called cortical superficial siderosis. The rate of ICH can be as high as 30 to 40% in that subgroup. And in those patients, often we have an upfront conversation about what is safe to put them on. Sometimes the answer is nothing. They don't even want them on antiplatelet therapy. They don't want them on aspirin. And then we just have a very involved conversation with the patient that theoretically there might be an increased risk of DRT. If you were to get DRT, we'd be in a pretty bad place, but that none of the observational studies have shown that even with nothing and single antiplatelet therapy. So it's not a totally sort of careless risk that we're taking, and try to get the patients involved, the neurologists involved in making that joint decision. But we have treated patients that are not able to be put on anything for a variety of reasons.
I'll ask a question. Less science, more just to be provocative. We spend a lot of time talking about just in the LAAO space. Many trials, this trial, that trial. AtriCure, which is a surgical clip device that is put on like as someone is unscrubbing, and then like with a long reach is just like clip that sucker off and walk out. Nobody ever really studies that. And in fact, as you know from sharing a clinic with a surgeon, as we all do in the interventional space, it's almost like, and let's not say weaponized, but it's a like little carrot that's used to be like, well, you can have surgery and we'll clip your appendage like on the way out the door. Very different kind of mindset and framework than spending an hour talking about all the randomized trials on whether we should do it or shouldn't do it and when should we do it. Are they being too, I mean, not to speak ill of anyone, but these mindsets are so different about basically the exact same thing. How do those comport?
So I think with surgery, we have just historically had the mindset that if you're going to open someone's chest and heart, you kind of just do everything that's reasonable to do and kind of as much that may be reasonable to do. And so that practice really has not been tested because I think just rationally it makes sense. So I think that is sort of like the historical origins of that. And I don't know that we're going to be able to necessarily change that and demand like randomized trials for every component that can be done in a multi-part cardiac surgery. I do think that with surgical ligation, because it was not necessarily tested as a way to get people off of their anticoagulant, in a lot of cases, the expectation up front is that you clip it, but people stay on their anticoagulant. So it is a little bit different. I think it is the exception as opposed to the norm in surgical ligation that you tell people that, we're totally confident getting you off of a NOAC, especially in a high-risk patient. The sort of other nuance to that is, with the external ligation, you're not leaving any foreign object in contact with the bloodstream. So there's no risk of device-related thrombosis that you may be trading off there. So I do think that we are required to bring a little extra vigilance to assess for that with percutaneous devices that is not necessarily required for surgical devices. But I agree, I think a lot of studies have shown that these surgical methods are not perfectly successful. They're not perfectly durable. Many of them go on to have significant leak, and we don't know exactly what to do with these patients, and often they're all just staying on anticoagulation. So I think, yeah.
Yeah, I was wondering, thank you for the wonderful talk. I was wondering, in the population with cardioembolic stroke of unknown etiology, what is the magnitude of benefit of aspirin versus placebo? And do we know that if anyone has tested Plavix versus aspirin?
That is a great question. I don't know off the top of my head of trials of aspirin versus nothing, but I would presume based on the event rate that you see in the aspirin arm of the PFO closure trials and the ESIS trials, that the rate of stroke on nothing would be significant. If the risk of recurrent stroke of a PFO-associated stroke in a patient on aspirin is 1% per year, then the risk on nothing would presumably be significantly higher.
Some of the concern with Watchman and even Watchman Flex, particularly in the original PROTECT study, is the increased rate of strokes. There's been a lot of realization recently that even up to 50% of them have micro leaks around them. Do you share any of this concern that potentially the increased risk of stroke was actually due to the leaks and not actually device-related thrombus, and that we still may be not totally aware of what's going on there?
So I wouldn't necessarily say there was an increased risk of stroke. The difference in the PREVAIL study, which I think is what you're referring to, was like a difference of 2 or 3. So one group had like 2 or 3 strokes, the other group had like 4 or 5 strokes. So I think it's really hard to make much of that. The original Protect AF study did not show increased numerical rates of stroke in the Watchman group. In the Protect study? Okay, I guess I was thinking of the primary efficacy endpoint that was a composite that also includes mortality. Yeah. So there was this big registry analysis from the NCDR looking at rates of mild, moderate, and severe peri-device leak, and looking to see how that associated with ischemic stroke. And there was a small increase in risk for the mild. It was like 1.1 hazard ratio, and then a little bit higher for moderate, and then significant for large. And I think it conceptually makes sense that if you're not completely occluding the appendage, that, you know, clots are going to be able to get out. So we do think that probably any leak is not totally okay, and that no leak is better, of course, than having even a tiny leak. And that does factor into the conversation if somebody is perfectly able to tolerate anticoagulation and is seeking to come off of it for primarily a preference and sort of lifestyle issue. It's a very different conversation. And I explicitly tell people, you know, that I don't know that the trade-off is worth it to accept any residual risk of stroke that remains unknown for somebody like you that can tolerate being on a blood thinner. And I tell people we have these larger randomized trials coming up. It'll give us more information to know whether we can really confidently say, like, yeah, you know, you can choose this. But I generally discourage many of my low-risk patients from proceeding with Watchman because of that unknown residual stroke risk.
Well, I think we're at time. I actually don't have a watch, but we're probably at time. So thank you so much, Christine.